Hello everyone and welcome back to IPC in Action, our infection prevention control podcast. I'm Fran, I'm one of the infection control nurses.
Hi everyone, thanks for listening. And I'm Jen, I work with Fran within the team. I'm one of the senior infection control nurses.
So we're going to start off by doing something a bit different, doing a mini series on the team, what we do, different roles within the team, because there are lots of moving parts and we do a lot more than I think people think that we do.
We are not the hand hygiene police.
It's very multifaceted and we get a lot of people commenting when they come and spend time with us that they're surprised at what else we do, because they think hand hygiene.
It's a really weird job, like Fran has alluded to, with lots of different moving parts.
Yes.
And on that note, we do have an exciting opportunity within the team. We have a 12-month fixed-term contract coming up for a Band 6 infection prevention and control nurse, and this is to cover maternity leave. So
one lucky person is going to get to come and work with us. We're all very friendly. We've got a really good team around us, and you will learn a lot. Let me tell you.
So the job is live. We can include a link on the bottom of this podcast when it goes out, and we would welcome any questions if you want to come and spend some time with us, if you're considering it but you're not quite sure what the role entails. First of all, listen to this episode, which we're already doing,
and all the rest of them if you've got time.
And but come and spend some time with us, and if you've got any questions or anything, it's a full-time 12-month fixed-term Band 6 contract. That's a lot of words.
Exactly. And we're very excited to have someone possibly join the team with us for a short time. And so
while we're doing this sort of mini series on who we are and what we'll do, it's just Fran and me today, but we will bring on some other sort of
additional guests.
Exactly, additional guests, different members of the team to come on and explain what their role is within the infection control team and the slightly wider teams as well, which will be really good, I hope.
Yeah. So we'll start off talking about the infection prevention and control team, the acute IPC team. So the team is made up of, we're a very small team, we're a very close-knit team. So in our team we have 4 Band 6s, we have 2 Band 7s, we have a lead nurse who's a Band 8, and then we have our Deputy Director of Infection Prevention Control and our Director of Infection Prevention Control. Alongside that, we have 2 Infection Prevention Control doctors who are consultant medical microbiologists as well. So we all work very well together, and like I said, close-knit team with a lot of responsibility.
Yes.
So speaking of responsibility, we're just going to go into what some of our kind of job responsibilities and what our role duties include. So as a lot of you have seen, we go out, we support patients, we conduct C. difficile ward rounds, we conduct MRSA ward rounds, and generally seeing all manner of results, really.
Yeah, absolutely. We run a nurse-led service for the administration of sort of more novel C. diff infection therapies, such as FMTs or fecal microbiota transplants. And we're very proud to say that this is a fully nurse-led service. Kerry, our deputy director, is a prescriber within the team. I am now a prescriber within the team, and Fran is shortly to be. So we're becoming more and more sort of independent in those extended roles, which is really, really exciting.
Yeah. And we've been able to branch out that service to county-wide.
Well, and wider,
wider.
We've had referrals from out of county as well, which is it's really exciting. It's a really, really fantastic service that we can offer our patients with really beneficial effects.
Yeah. But again, that's very multifaceted. So if you want to know more, just let us know, because that's a big one of what we do. We also give a lot of support, a lot of advice to staff with infection prevention control issues. As a team, because we are obviously working in the acute service, we are answering and supporting with questions and queries about patients. Any staff member queries are to be directed towards the Working Well team, but we're dealing with queries about patients.
Yeah, and we work really closely with lots of other teams, especially in the sort of winter and outbreak season. We work really closely with the site management team. We've got really great relationships with them, just to try to support flow throughout the hospital when outbreaks obviously can have a massive impact on that.
And I think another thing that we do that people think is quite a typical role of an infection control nurse is completing audits. And yes, we do audits. We do a lot of audits, but we make them as meaningful as possibly can, get as many people involved as we can from the area that we're auditing to make it so we can have actions from it that are going to improve practices in the area.
And really drive forward like quality improvement rather than just like a tick sheet for the sake of it.
Exactly.
That is not what we are about.
We don't just want to rock up, be like, are they doing their hand hygiene? Have they got PPE on? Is being cleaned correctly? We want to make it useful to take forward.
We do lots of teaching.
We do.
We do sort of teaching in-house. We are also fortunate enough that we are sometimes able to attend like external study days. Myself and Kerry, we are very involved in the sort of Southwest IPC regional network, and we plan a annual study day with that network, which we send out within the organisation, which is a free to attend study day, and we will be planning for one next spring.
We have the responsibility of reviewing educational packages, so our e-learning, any distribution of kind of materials in relation to IPC will have involvement in some way. Action cards, policies we have involvement in. So as Jen was alluding to earlier, especially in outbreak season, but generally all year round, we have participation in divisional meetings, system-wide meetings, a lot of involvement with the site team, which is really useful and definitely builds up that communication between all of us.
Yeah, absolutely. And considering this sort of wider integrated care system, we've got really good links with colleagues within the ICB and within other external bodies that we quite often need to be in contact with, like the UKSHA. UKHSA. I always say it wrong. Sorry. And yeah, having that networking ability with these wider external bodies is a really integral part of our day-to-day role, isn't it?
Yeah, absolutely. There's so many more things that we could go into.
I don't think we could go on all day about this.
We would be sat here all day and all want to listen. So again, we're going to run through we have different roles within the team on a day-to-day basis. So the way that we work is that we are allocated to a role on a day. So we're either going to be the reactive role, or we're going to be a clinical role, or we might be on a divisional focus / quality round role for the day. So the typical day for one of us who's on reactive, and this is between the band 6s and the band 7s, it varies. We do different things to kind of mix it all up a bit. So in the life of a reactive role on a particular day, we'll be coming in and obviously looking at, are there any outbreaks in an area, whether that be of norovirus, COVID, influenza, all of the kind of
any of those lovely bugs that plague our hospital.
That we'll be seeing more of in the months to come. So we manage those on a daily basis. We visit the area, check for any issues, check if there's anything we can do to ensure patient safety.
Yeah.
Expedite.
Sometimes it's as simple as speaking to stores to make sure that they've got appropriate levels of PPE to support them, especially if we're going into a weekend or a bank holiday or something like that.
Exactly.
It is what it says on the tin. It's reactive. We are reacting to whatever is coming in that day. Exactly. We want it to be as on the floor as possible. We want to be out and about in the clinical areas. We can also just answer queries from people face to face at that time. It's a lot easier and it's a lot more personable when we're doing that within the clinical areas.
Yeah, absolutely. We obviously take a lot of phone calls. We answer a lot of emails with queries. However you want to get in contact with us is absolutely fine. We are looking at alerts. We get we have a system whereby we can see if people have been readmitted into hospital, if they've had a history of, say, CP, for example, and then the actions that we need to take from there on. And yeah, just as Jen said, reacting to whatever comes in the day, and it could be anything at all, literally anything.
I don't think I've ever had like 2 days the same in this team, and I've been in the team since 2016.
Exactly.
So one of the other roles we do is clinical. So if you are on clinical for the day, your main responsibility is reviewing your patients in the hospital. We work across sites, so there's a clinical person in Cheltenham and a clinical person in Gloucester, and we are reviewing those patients who have an active or have a history of a C. diff infection. Mm-hmm. So some of those people are being actively treated for a C. diff infection. So we'll go out and see each of those patients, see how they're responding to their treatment, carry out that real holistic assessment to see how they're getting on, and whether or not they are responding well to their treatment, or whether or not we need to consider escalating that to a second line treatment. Or we will sometimes pick up patients who may be eligible for an FMT, one of those novel therapies that I mentioned earlier.
So in that role going out as well, we have a lot of involvement with clinical teams. We always discuss with them, our recommendations, because we see diffs pretty much every day. So we have that great involvement between us and the clinical teams as well.
And we have our own links with our infection control doctors who are also microbiologists. So we have a meeting every day and we're able to touch base with them just to chat through any queries, anything that we can do to optimise the treatment and safety of our patients, really. But it's really helpful having those links with them and having that relationship with them so that we can make sure that antibiotics and so on are optimised as much as possible.
Another sort of area of that role is that, again, as I was saying earlier with alerts, we every patient that has had an episode of C. diff, whether that be in the community or whether they've been in hospital having it before, they are tagged and we get an alert that they've been readmitted. We receive a list every morning. We then will review those patients to see what they've been admitted for. Have they been admitted for potential C. diff, diarrhea, abdominal pain, etc., just to try and get in there early to put in the precautions.
And make sure they're not on any high-risk antibiotics, because sometimes people will come in and clinical teams may not necessarily notice that they have a history of C. diff, as it could have been a result from a number of years ago. But we just want to make sure that there aren't high-risk antibiotics prescribed for that patient for the obvious reason that we don't want them getting C. diff again.
So the other role that we have is what we call divisional focus. So between us all, Band 6s and the Band 7s in the team, so our 2 Band 7s have our lead infection prevention control nurses for across the 4 divisions. So for example, Jen leads for the medicine division and for the diagnostics and specialities. And then we have Geraldine, who's the other Band 7, who leads for women's and children's and the surgical divisions. So when we say divisional focus, we are, doing things like meetings. Jen and Geraldine will have their reports. Meetings.
So we have like monthly reports that we do with our DDQNs, which are a really helpful way of touching base with them. Those reports then feed into ICC, which is the Infection Control Committee. It's our time to try to sort of catch up a little bit, to be honest.
Yeah, exactly.
Do a bit of admin.
Trying
to keep on top of emails and so on, because we get a lot.
Yes, exactly.
And like Fran said, carrying out investigations. We also do a lot of quality rounds. So this is where we're sort of just out in our areas, checking in, really, checking that everyone's happy, everyone understands the processes, and if they're needing any additional support, they may have new starters who might want a bit of a infection control refresh, or they may be brand new to the organisation, may need to start from the beginning. And we always welcome student nurses, new starters. Anyone and everyone is very, very welcome to come and join us shadowing for a day or more, if you wish.
There are also, there are so many different things going on in each division, lots of nuanced things that we do, very kind of down to the very detailed stuff. So, for example, I joined Jen in the medicine and DNS divisions, and then Sophie and Shinsley joined Geraldine in surgical, women's and children. So we have that rapport with the staff. We have the rapport with the staff everywhere, but
we hope.
yeah. So we try and build up that relationship as much as we can.
Now, what do we do when everything goes belly up?
So yes, and as we all know, it happens in winter.
It does. It happens in winter, and it also quite often happens on a Friday. Stuff likes to come in on a Friday. Like suddenly, somebody with suspected measles will rock up in ED, and it will be, okay, we are going to down tools. We are going to prioritise patient reviews.
Yes.
Everything else waits.
Yes.
And we go to the area that needs us, and we help them with whatever's going on. And for instance, hot water in Cheltenham.
Yes, exactly.
When stuff like that happens, we down tools, we help where we're needed, but what we always do is prioritise the patient results, the patient reviews, because they are obviously who we're here for.
Exactly. In that instance, we're taking on the reactive role as opposed to a proactive role, which is everything else we do when we don't have to down tools.
Yeah,
and all hands on deck. Couple of other bits that we will just skim over because they're very, very in depth is the other things we're involved with. So we're involved with building work, so whether that be new builds or refurbishments of particular areas. We have an involvement right from the off in terms of infection control precautions.
Yeah, we want to make sure there's really strict guidelines that need to be followed to make sure that these areas are meeting the IPC specifications required, and we don't make them up. These are given to us from sort of health technical memorandums and all sorts of technical documents that we follow to make sure that these areas are going to have the longevity and meet the required specification to keep people safe.
Exactly. So that was pretty much everything, and I feel like there's there's so much more we could go into, but we don't want to bore anyone. It is an exciting job, and we do so much. But if anyone's interested in coming to find out more about what we do, please let us know. We're very happy to have anyone and everyone
absolutely
come to spend a day with us. Or
not just nurses. We want to see everyone.
Yeah, absolutely.
Yeah.
So as usual, to get in contact with us, our acute ICN email address is on the global. We are working Monday to Friday, 8:30 to 4:30, and our extension numbers are 6122 for Gloucester and 3129 for Cheltenham. Thank you for listening, and we will see you next time.
Thanks, everyone.
Bye.